Okay, video as promised for the week 3 MCQ session. This particular question here, this is a classic that I've seen quite a bit in the MBME, so we've chosen a few of these for your final exam. I call these the up and down arrow questions. So this is looking at multiple components of a single system and what is increasing, what is decreasing. So I thought I'd put this one in here to make sure that you're aware of these types of questions and you're comfortable with them. Okay, so this particular one here, during a study on gastrointestinal hormones, a volunteer is administered a hormone secreted by S cells. Okay, hormones secreted by S cells, so we know that this is secretin. Okay, which of the following changes most likely represents the effect of this hormone on gastric and duodenal secretions? Okay, so we know the secretion is recognizing the high concentration of protons. So these are the S cells that recognize this drop in pH and now increase secretin. And the job for this is to increase bicarbonate secretion and water from the pancreatic duct cells. Okay, so we know this already. This is the basic knowledge. So now let's look at our answer choices here. So the first thing we're going to want to do here is increase our bicarb. So this looks good. This looks good. Okay, it's not going to decrease. It's not going to have no change at all. Now, the other issue is gastric pH, the hydrogen ion concentration. So remember, this is going to mop up those hydrogen ions to increase the pH to try to get it back to neutrality. So it is going to decrease gastric proton concentration, protons coming out of the stomach. So it looks like from our choices here, it looks like this one here. Now, I would say that D is probably the correct answer just from these two here, but let's confirm it by looking at the duodenal concentration of chloride ion. It says here that this decreases. So what exactly is happening here? Remember that on the basal surface and on the apical surface, if this is the lumen of the pancreatic ducts, we are shifting bicarb into the lumen. But remember, this is a co-transporter, and so we are moving chloride ion out of the lumen and into the cell and into the interstitial space. So that means in the lumen, we are increasing our bicarb concentration, consistent with choice D, and we are decreasing our concentration of chloride, so that confirms this answer. So this is choice D, is the correct answer. Okay, the next question. Let's look at some liver issues on here. A 41-year-old woman comes to the physician because of an 8-hour history of colicky abdominal pain and nausea. The pain worsened after she ate a sandwich, and she vomited once. Okay, so something's going on here. She's not happy with this meal. She has no history of serious medical illness. Her temperature appears to be fairly normal. Pulse is a little bit high. Blood pressure, a little bit high. Physical exam shows scleroicterus. Okay, so now we've got a presentation of jaundice. Diffuse tenderness in the upper abdomen. Okay, so now we have some potential based on this that we might have something going on with her liver or gallbladder. So here's our lab tests. Total bilirubin. That looks a little high to me. AST, maybe not so bad. I'd say that's probably normal. These levels I think are normal up to 50. Alk Phos, whoa, that is high. Very high alk Phos. And high GGT. Okay, GGT is another enzyme that is involved in cell surface protein and amino acid activity, but this is another important liver marker. So high alk Phos, high GGT, ultrasonography is most likely to show a stone located in which of the following structures? Okay, so now we have jaundice from the elevated bilirubin concentration here. we have increases in alkaline phosphatase. Now, increases in alkaline phosphatase, alk-phos, typically suggest a bile secretion issue. Okay, so this might be a problem with the biliary tree, bile delivery. So we're looking for a stone. Okay, so now we're looking for a stone. It's telling us that there's a stone somewhere in here. Now what this question is focusing on is, do you know your anatomy? And so at the beginning of the block, when we talked about the material that Dr. Hartley was talking about, I mentioned about knowing your biliary tree anatomy, because the location of a stone will indicate what the blood tests can be and where the problem might be. Okay, so common bile duct, common hepatic duct, cystic duct, gallbladder neck, pancreatic duct. Okay, so she doesn't seem to have a real serious problem here. She's got some pain after eating. So after eating would indicate CCK, squeezing on the gallbladder, and that could be causing pain. We're seeing the pain in the tenderness in the upper abdomen, so that's consistent with CCK causing contractions. Nothing in this presentation here is indicating pancreatitis, okay, acute or chronic. So I would say that the stone is probably not in the pancreatic duct. You would have other issues, for example, weight loss, because if we have problems with the pancreatic duct, we're not putting out enzymes for digestion and absorption, so it's going to have absorption problems. We're also would be having enzymes here in blood that are pancreatic lipase, for example, would be presented to you, and that would be elevated if we had pancreatic blocks. Gallbladder neck, okay, gallbladder neck and cystic duct. Okay, these are pretty comparable, right? Cystic duct leading into the gallbladder from the common bile duct. Gallbladder neck would be there. So this would be a problem that would be consistent with the vomiting and tenderness in the upper abdomen from CCK contraction. Okay. However, if we have a problem in the cystic duct or anywhere near that gallbladder opening, would we have jaundice? Okay. Would we have elevated bilirubin? Probably not. So this problem here is going to cause pain, but it's not really going to cause many liver problems because the liver can still secrete the bile components and still function properly. So the common hepatic duct, if we had problems here, if we had a stone located in the common hepatic duct, that would indicate that the CCK would be compressing the gallbladder, and it wouldn't really have much tenderness because the gallbladder would be responding normally and just pushing out its contents, whatever contents it would be. So this would also lead to jaundice, but it wouldn't lead to the tenderness in the upper abdomen. Common bile duct. Okay, so now we have three ducts that come together. One is the cystic duct from the gallbladder, the hepatic duct from the liver, and the pancreatic duct from the pancreas. The common bile duct is the one that joins the gallbladder plus the liver. Okay, pancreas seems to be fine. Here we have a problem with a stone here. We are going to have liver jaundice issues, and we are going to have tenderness in the upper abdomen upon eating because the CCK secretion is going to contract that gallbladder. So in this case here, choice A would be correct. Okay, let's see. Next question we have here. A 47-year-old man with gastroesophageal reflux disease, GERD, comes to the physician because of severe burning chest pain and belching after meals. He has limited his caffeine intake and has been avoiding food close to bedtime. Okay, so burning pain, he's got a history of GERD, so probably an acid-related problem. Burning pain, belching after meals, this is mean he's not digesting properly. He has limited his caffeine intake. This is important. This is probably self-prescribed. because this can cause esophagitis, and it can exacerbate the problem of GERD, and has been avoiding food close to bedtime. This has to do with the belching after meals, because this can cause aspiration. As a person lies down, reflux coming from the GERD can get all the way up into the airways. So, esophagogastroduodenoscopy shows, so this is pretty clear, right? It goes down the esophagus and through the stomach and pokes through the pyloric sphincter to take a look at that duodenum. Shows erythema, redness and swelling, and erosions in the distal esophagus. Okay, so we have erosions which could be leading to ulcerations. So this looks like a very severe acid problem. Which of the following is the mechanism of action of the most appropriate drug for this patient? Okay, enhancement of the mucosal barrier. So this would be the sucralfate that Dr. Shuttleworth talked about. This is important for covering the erosions in acid to prevent them from further acid damage, but it's not going to take care of this problem. Inhibition of D2 receptors, probably not. That's not going to be taking care of the acid problem. Neutralization of gastric acid. Okay, this would be our bicarb solution from like Alka-Seltzer. That would be an immediate response, but how long does that last? Not very long. We need to really take control of this person's acid problem. Inhibition of H2 receptors. Here is our cimetidine, ranitidine, famotidine drugs. These are very good at reducing acid, but this individual has some severe acid reflux problems, and he also has erosions that can lead to ulcerations, which can lead to a GI bleed. So we want to prevent that as quickly and as effectively as possible. So let's go for the PPI in this case. Okay, inhibition of the potassium proton ATPase pump. This will give an absolute inhibition of acid secretion and get this under control while healing can occur. Okay, so choice E would be here on this one. Okay, this one here, a 75-year-old man comes to the emergency department because of sudden onset of severe throat pain and dysphagia just prior to arrival. He says he was eating steak, heavy meal, suspects a large piece of steak is stuck in his throat. He denies shortness of breath, chest pain, and abdominal pain. So this looks pretty much like it's going to be something in the airway. He is drooling slightly with increased saliva in his mouth. Okay, the increased saliva, this is going to be from the vagal response, from the parasympathetic response because of that food coming in. There is no erythema or swelling to the oropharynx. Okay, as far as you can see, everything looks good. Which of the following physiological process assists in clearing a large food bolus from the esophagus? Okay, so now this gets into the control of motility. Migrating myoelectric complex? No, right? This is in the lower bowel area. And this is the pace setter that controls peristalsis and makes sure that we have directional movement. Receptive relaxation. Now, does this involve in clearing large bolus of food from the esophagus? Okay, well, you could potentially say that there is an opening of the LES. Remember that lower esophageal sphincter opens and relaxes as soon as the food passes the upper esophageal sphincter, the UES. And that coordinated opening of the LES makes sure that those real propulsive movements of the esophagus do not slam the food into a closed sphincter. This is open and ready to receive the food. Okay? But it's not involved in clearing a large bolus of food. It's just involved in making sure that the peristaltic wave is productive. Retropulsion, well, this could be a vomiting reflex, right, going backwards, but he hasn't experienced any vomiting, so this is not really happening. Reverse peristalsis, this is also part of the vomiting reflex, and he hasn't reported anything like this. He's not showing any of these signs. Secondary peristalsis. Here's our answer. Okay, so why do we have this? This is simply, as Dr. Shuttleworth talked about, the primary peristalsis. That primary event is part of the swallowing effect to make sure that the food passes down in one sweeping motion. And it typically should only take a few seconds to get food from our oral cavity down into our stomach. Now what happens if that we are eating steak and we didn't chew it very well? 75, he may have some dental problems, he may have problems with dentures, so he might not be chewing his food well. That first bolus, the primary peristaltic wave, is trying to push that down. Now if it doesn't clear, remember, it still remains in the esophagus, so it's going to cause a distension of the esophageal walls, and that is going to trigger a secondary peristaltic wave to push that food down into the stomach. Okay, so it's a redundant mechanism to prevent us from choking. Okay, next question. We have here a 55-year-old woman presents with acute onset abdominal pain radiating to her back, nausea, and vomiting. Wow, this is pretty serious. CT scans suggest a diagnosis of acute pancreatitis. Okay, so now we know what the pancreas is going to do. This is going to be secreting our digestive enzymes under normal conditions. So if we have acute pancreatitis, that typically means that the pancreas is not performing its normal function of secretion. The pathogenesis of acute pancreatitis relates to inappropriate activation of trypsinogen to trypsin. Okay, the activation of trypsinogen. So what's going to happen if it's inappropriate? That's the key here. Normally the pancreas will secrete the zymogen, trypsinogen, and then this gets into the duodenum. Then we have activation. That is the normal sequence. If we have inappropriate activation, that means this is going to be converted into trypsin. And remember, I said there is a slow activation sequence. This is called autoactivation. And this happens under all conditions in everybody with trypsinogen. The key element here is that it's slow because it's an autoactivation sequence. So slow typically means we normally have CCK causing secretions and contractions inside that pancreas to push those secretion products out, and so we never really have this problem because the autoactivation is slow. But if we have acute pancreatitis where we have slowed movement of our secretions out of the pancreas, now we have enough time for autoactivation to occur. Okay? That's all true. Now the question, which of the following activates trypsin in normal digestion? So activation of trypsin in acute pancreatitis is an abnormal activation. The question's asking for normal. Okay. Amylase? No. This is for starch, carbohydrates. Lipase? This digests lipids, triglyceride structures, cholesterol esters. Cholecystokinin? Does that activate trypsin? No. It induces the secretion of trypsinogen. Okay? But it's not involved in the activation. Enterokinase? There we go. This is on the intestinal brush border, which is the epithelial layer facing the lumen, and this is involved in activating by cleaving the trypsinogen into the trypsin. So I'm going to say choice D is correct. Secretin, of course, this is to increase water plus bicarb secretion from the pancreas. Okay, so could secretin be a problem in an abnormal pancreas? You bet, absolutely. It's cholecystokinin activity in acute pancreatitis. Sure. So imagine if you've got acute pancreatitis and you have a problem with the pancreatic ducts so that the secretion is not being pushed out, but you still have secretory products being made. This can cause pain radiating to her back with nausea, accompanying nausea and vomiting. Okay, so that would be under pathological state of the pancreas, but under normal conditions, trypsin is activated by the enterokinase enzyme. Okay, what do we have next? We have a 65-year-old woman who comes to the physician because of progressive weight loss for 3 months. Okay, obviously this is probably not a planned weight loss, so she's coming to you. Physical examination shows jaundice, okay, non-tender palpable gallbladder, okay, so that sounds to me like things are starting to come apart on her with the jaundice here. We've got liver issues. A CT scan of the abdomen shows an ill-defined mass and the pancreatic head. Okay? So now, what is the pancreatic head? This is the portion of the pancreas, remember in anatomy, that is closest to that junction of the common bile duct and the duodenum area and where the pancreatic ducts are. She is scheduled for surgery to resect the pancreatic head. Okay, so ill-defined mass. This sounds like it's a pancreatic tumor that needs to be removed. So that's being removed. She's also must have metastasized to its local environment because the distal stomach is being removed, the duodenum, the early jejunum, gallbladder, and common bile duct, and anastomose to the jejunum to the remaining stomach. Okay, so this is kind of one of those pull-through like surgeries, pancreas and bile duct. Okay. Following surgery, this patient is at the greatest long-term risk for which of the following? Okay. So now, with this particular case here, hypercoagulability state. Okay, so is she producing a lot of coagulation factors that could increase her risk? Well, this is going to be largely a liver enzymes, liver proteins that are being secreted. Liver seems to be fine. She's having a little bit of jaundice, probably because this mass at the pancreatic head is squeezing that common bile duct, causing some jaundice. Microcytic anemia. Could she develop microcytic anemia? So let's put a question mark on there. Assuming that the junction here that the surgeon is promoting should be fully sewed and there's no bleed in here, it sounds like there shouldn't be a problem with microcytic, which is iron deficient. So let's come back to that one. Calcium oxalate kidney stones? Probably not. I think that's just thrown in there for as a distractor. Wide-based gait? No, I don't see how this is going to affect her mobility. Increased bile production? No, this type of surgery and removal of this is not going to really affect the bile production. What does affect bile production? How about increased cholesterol? Increased cholesterol, remember, will push the 7-alpha hydroxylase enzyme into bile synthesis. Okay, so bile synthesis is largely controlled by the availability of the substrate for 7-alpha hydroxylase. So that's the primary role for increasing bile synthesis. Okay, so this doesn't look right, that doesn't look right. Let's go back to this microcytic anemia. Well, typically microcytic anemia is an iron deficient anemia. These are going to be those little small red cells, and it's typically due to a bleed. Okay, now under long-term conditions, is this going to cause a bleed? Well, probably not. There's nothing that's indicating in here that we're going to have a GI bleed because we have a tumor that's being resected and we have some local areas that has been the tumor has metastasized to, but there's nothing in here that's giving an impression that there's going to be a bleed. So, where does the iron deficiency come from? Resect duodenum and early jejunum. So where this is going is looking for the uptake mechanism for the cofactor iron. So iron, the transporter, is primarily in the duodenum and early jejunum. Okay, so remember this iron transporter? This is primarily the divalent metal transporter 1, DMT1. And so the iron needs to go from the Fe3 plus to the Fe2 plus. And so this is the reductase enzyme on the surface of the cell. That's the duodenal form. And it's going to go into the transporter and then be converted back into Fe3 plus for either bound to ferritin or delivered into the circulation. Now, this is a basic review of iron. The reason I do this is because the transporter for iron here is DMT1, which is located on the duodenum and early jejunum. So it's in the very proximal small bowel, real early on. So if an individual has this resected out, they're going to have their transporter deficient. Now, what else is important in this transporter? How about calcium? And this is a little side note I'm bringing up because calcium uptake can be deficient in here. And go back here, 65-year-old woman. So she could be also at risk for osteopenia or osteoporosis with this resection. So that needs to be watched also. So the correct answer here is microcytic anemia, primarily because her transport mechanism for iron has been removed. Okay. Let's see, do we have any more questions here? Yeah, I got one here. I think this may be, yeah, this is the last one. I think this is the last one. A group of investigators is performing a phase 1 trial of a novel drug among patients with chronic upper right quadrant pain. Okay, so that sounds like probably a gallbladder problem maybe. Aminodiacetic acid, labeled with technetium-99, is administered intravenously, and subjects are subsequently imaged with a gamma camera. Okay, so we have a compound here that is radioactively labeled with technetium-99, and we are going to perform an imaging study. Okay, so typically in my head this is telling me that it's being put in IV, and we're simply going to look for where this is going to end up to identify what this chronic right upper quadrant pain is. It is found that administration of the experimental drug here increases the amount of the drug in the intestines. Okay, so it's going from an IV administration into the intestines. The effect of this novel drug is most similar to that of a substance secreted by which of the following cells? Okay, so how is this getting in there? Duodenal Brunner's glands. Okay, so one of the reasons I wanted to include this question is because we have not talked about Brunner's glands. Brunner's glands are proximal, the majority of them, are proximal to the sphincter of Oddi. Okay, so this is in that junction area between the sphincter of Oddi where the pancreas is putting out its bicarb to neutralize the acid coming out of the stomach. Okay, this is what the pancreas is secreting. But remember, we have this danger zone that I call it between the pyloric sphincter and the sphincter where the bicarb is coming out to neutralize. So how do we take care of that? These are Brunner's glands. And Brunner's glands also secrete bicarb. And these will be the primary secretion of bicarb in order to neutralize that acid coming out until it gets to that real big pancreatic secretion of bicarb. Okay. Pancreatic D cells. Okay, D cells, remember D cells are somatostatin. So somatostatin is the brake. And so Unlikely, this is the big break, so this is unlikely going to be moving something through. It's usually going to be slowing something or stopping something. Antral G cells. Okay, this is gastrin. And this is something that our pathologists will talk about. Antral, the antrum of the stomach, is where a large portion, the majority of the G cells are located for acid production. So this is our gastric acid inducer. So this is gastrin secretion. Duodenal S cells. What is this? This is secretin. Okay, so this is job is to increase the water plus bicarb coming from the pancreatic ducts. Jejunal I cells. Okay, remember I cells are that CCK secretion. These are the intestinal cells. So this is going to be recognizing primarily fats and some amino acids to trigger CCK release, and then this is going to stimulate the gallbladder plus the pancreas. It's also going to cause relaxation in the sphincter vodi. Okay, so what this question is getting at is that this drug, this compound, is being injected IV, so it's in the blood, and then over time it's found in the intestines. So how does it get through there? Well, strange drugs, remember, typically are taken up by the liver, and the liver is going to be putting this through its P450 enzyme system for disposal, if necessary, and then it's going to be put into the bile. Okay? It goes to the gallbladder, and how do we get it from the gallbladder to the intestines? CCK. So under this condition, it looks like choice E is the correct, because CCK is the primary hormone of all of these choices here that is going to relocate this drug from the IV, from blood, into the intestines. So this is looking at the effect of the hormone and the path that these hormones are involved in. Okay, do we have another one here? Yeah, one more. Ooh, this is a good one. This gets into Dr. Shuttleworth's domain here. A 33-year-old man comes to the emergency department because of dry mouth and blurred vision for the past 30 minutes. Okay. So he's young, healthy, doesn't say anything about being ill. Prior to this, he was on a road trip and started to feel nauseous, dizzy, and fatigued. So his friend gave him a drug. Okay. Got to be careful. You choose your friends wisely. That had helped in the past. Okay. Physical examination shows dry mucous membranes and dilated pupils. Okay, so this is a result of this taking this drug. Remainder exam shows no abnormalities. That's good. Administration of which of the following drugs mostly likely to cause this problem? So, loratadine. Loratadine is an antihistamine, and this is for allergies. It's an awesome drug. I take this in the springtime, and it doesn't make me sleepy. Nice, okay. Epinephrine, no, this is in metabolic control. So he's not going to be taking epinephrine. Pilocarpine, metoclopramide, Dr. Shuttleworth talked about those. Here's where we're going here. Scopolamine. And scopolamine, remember, is that it's our patch that we put on behind our ear to prevent our motion-induced nausea. And the primary problems that that's going to cause is dry mucous membranes because it's inhibiting salivary secretions. Okay, so this is blocking that parasympathetic response on the M3 receptors that increase the flow of salivary ions and salivary water. And so this is one of the side effects on here. Also dilates the pupils, but it does help with the nausea and dizziness. Okay, I think that is, yeah, that's all of the questions that I had. So I hope this helps. If there's any questions about these, just give me a shout by email.